In this video I will discuss about secondary carcinoma. Metastatic spread of squamous cell carcinoma to the cervical lymph nodes is a common occurrence from head and neck primary cancers. Occasionally, this may be the sole presenting feature of the disease, figure 52.70. The upper aerodigestive tract mucosa must be carefully examined for a primary site before considering surgery to the neck nodes. When a primary site is not seen on clinical examination, they are most often found in the oropharynx. Appropriate radiological investigations, MRI, PET-CT, must be undertaken to define subclinical primaries, as management will be dictated by this. If radiological assessment shows no primaries, tonsillectomy and robot-assisted tongue-based mucosectomy are performed as a diagnostic procedure because the oropharynx is the most common site for a clinically and radiologically unknown primary cancer. Management. The management of malignant cervical lymph nodes depends on the overall treatment regime. If surgery is being used to treat the primary disease and the cervical nodes are palpable and less than 3 cm, they may be excised with the primary lesion as part of a neck dissection. If radiotherapy or chemoradiotherapy is used initially with resolution of the primary tumor, but there is subsequent residual or recurrent nodal disease, then this situation will require cervical lymph node dissection. Type of neck dissection. Classical radical neck dissection, CRYL. The classic operation involves resection of the cervical lymph nodes, levels I of E, and those structures closely associated, the internal jugular vein, the accessory nerve, the submandibular gland and the sternocleidomastoid muscle. These structures are all removed en bloc and in continuity with the primary disease if possible. The main disability that follows the operation is weakness and drooping of the shoulder due to paralysis of the trapezius muscle as a consequence of excision of the accessory nerve. Bulky nodal disease may dictate the need for a radical neck dissection, but this operation is less commonly performed owing to a better understanding of the lymphatic drainage of axial computed tomography scan demonstrating a large cystic metastatic node from an unknown primary. Core biopsy confirmed a squamous cell cancer. The primary sites and as most patients with advanced disease need adjuvant radiation. Modified radical neck dissection. This term denotes a procedure in which one or more of the non-lymphatic structures are preserved, the accessory nerve, the sternocleidomastoid muscle or the internal jugular vein, with clearance of all nodal levels, I of E. Selective neck dissection. In this type of dissection, one or more of the major lymph node groups is preserved along with the sternocleidomastoid muscle, accessory nerve and internal jugular vein. In these circumstances, the exact groups of nodes excised must be documented. It must be noted that, when neck dissections are performed for residual disease after chemo, radiation therapy, the neck is often fibrotic and scarred and the operation may not fall into any of the above categories. For instance, lymph nodes in levels 2 and 3 may be removed, along with the sternomastoid muse CLE for access. Thus, meticulous annotation of the procedure is more important than ascribing a name to the operation.